everybody. In case you don't know me, I'm Dr. Ben Weitz, and thank you for coming for the Democratic debate tonight. I wanted to use this opportunity to announce my new healthcare plan, my national healthcare plan, which will include $10,000 to be allotted for functional medicine every year. In addition, there'll be $5,000 you'll be allowed to spend on lab testing and $5,000 a year on nutritional supplements. And all of this will cost less than the average cost to treat a patient with diabetes or autoimmune disease or cancer. Seriously, though. Thank you for joining our functional medicine discussion group. And I want to tell you about some of our future meetings. For those of you who don't know, we have a closed Facebook page, Functional Medicine Discussion Group of Santa Monica, and we have discussions, we post the future meetings, and etc. And so upcoming meetings are Fertility with Denise Weisner on July 25th. August 22nd, Male Hormones with Dr. Howard Leibowitz. We haven't gotten a reservation yet, but Tom O'Brien wants to come and speak, so we're going to add an extra meeting. He's going to speak on September 5th, if all goes well, on autoimmune diseases. September 26th, Female Hormones with Dr. Felice Gersh. Please check out my Rational Wellness podcast, which is available audio version. You go to Apple Podcasts and video version on YouTube. We've had some great guests this week. Is this interview with Dr. Chris Shades, who's brilliant, and I've had recent interviews with Dr. Mark Pimentel and Allison Seebecker. Many thanks to Metagenics for sponsoring this meeting, along with Boston Heart Diagnostics. I wanted to give a plug to a Metagenics supplement, I don't know if everybody here uses Metagenic supplements. If you do, that's great. Everybody will get up to a 20% discount for your next order of supplements. There's a discount code on a flyer at the front desk, so take advantage of that. This is a product that Metagenics has for cardiovascular disease prevention. It's really a neat product. It's a combination of, this is called Corentin. It's a combination of Reggie's rice, plant sterols, and vitamin K2, which helps reduce arterial calcification. So it's a really neat product. Let's see. Somebody from Boston Heart Diagnostics Testing, which is one of our sponsors from tonight, is going to tell us a little bit about Boston Heart Diagnostics.
For announcement. So my name is Jean Lee with Boston Heart Diagnostics, and I'm actually the area sales manager for the San Francisco Bay Area. So most of you guys may know Heidi Ann Mooney. She's actually currently your rep. She was recently promoted, so she's actually driving right now across the country to Connecticut. So I actually flew down here, but I just wanted to take just a couple minutes to make an exciting announcement about Boston Heart Diagnostics. We are launching next month a new division geared specifically towards functional medicine physicians like you guys. It's going to be called Empower DX, so it's going to be a division of Boston Heart, and it's going to be operated on a cash model only laboratory. Very similar to Boston Heart, we will continue to have the color-coded test reports along with the diagnostic booklet that has the patient's name and all the therapies in there, as well as their results. And I'm just going to borrow this from you. And we're also going to have a special personalized nutrition and life plan that's specifically now geared only to functional medicine. So this is going to be huge. We're going to be launching next month. We just hired 12 new reps to promote this across the country. And we're going to actually have the best cash prices that no other laboratory will be able to beat. So we just want to make it affordable and upfront for patients because, as you know, a lot of the managed care plans and insurance companies are just reducing the reimbursement rate. So it's not going to just be cardiovascular, but we're also going to be able to do a lot of genetics off the buccal swab. as well as hormone testing, thyroid, micronutrient testing, and a lot to come. So once we get that on the way, you will see a rep come and promote that over to you. But without further ado, just wanted to have you introduce Dr. Elkin.
Our topic for tonight is integrative cardiology, which you might have figured out, with my friend Dr. Howard Elkin. Dr. Elkin has practiced integrative cardiology for over 30 years. His main practice is in Whittier. He's been building a concierge practice in Santa Monica at my office. He's there on Tuesdays now. And as an integrative cardiologist, Dr. Elkin will address how to best stratify one's cardiac risk using the latest in cutting-edge lab testing. After all, it's not merely how low someone's cholesterol is, but one's actual risk of contracting a heart attack or a stroke. Dr. Elkin.
Okay, I feel like this is my home group, because I've been with this group almost since the beginning. But I want to start off with a case history, because I think case studies are always relevant, So let me tell you about this middle-aged man, about the early 50s, and he no history of any cardiac problems. No history of hypertension, he was a smoker, he was athletic, normal weight. Anyway, so he wakes up one evening, actually early morning, about 2 a.m., with what was like heartburn, like retrosternally. And lasted a few minutes and then went away. And then he came back about 2 hours later with vengeance. It's like, oh, this is really strange, he said. That went away after a little bit of meditation and so forth. And then next he woke up, then he woke up at 7:30 and feeling pretty well. And he went to work, did his usual things, felt perfect actually. And then around 10:30 or 11 that morning, he developed this cold sweat, broke out a cold sweat. Maybe it's hypoglycemia because I didn't eat. So he happened to work in a medical building, and he was able to get an EKG, which was read as being normal. And then he worked about 2 o'clock that afternoon. Thursdays was a half day for him. Then so I said, well, I might as well go to the gym. I'm feeling really good now. So he went to the gym, had a perfect workout. And after he finished his workout, I said, well, I think I'll stick around a little while to some of these ab crunches, those ubiquitous ab machines. So he's doing these ab crunches, and then all of a sudden his arms feel really heavy, like 50 pounds each. And now he's getting a little worried. So he calls his friend, found his phone, he calls his friend Barry, and said, Barry, my arms are like they're 50 pounds each. He said, Howard, your arms are 50 pounds each. And I think you should be calling a doctor and not me. So this person I'm talking about was me. I actually was in the throes of a heart attack and was totally clueless. Didn't know anything was going on. I had no family history and no risk factors. But I'm here to tell you that this can happen to anybody. So I ended up, and if you want to hear it, I got to Cedars emergency room that day at 4:30 p.m. traffic from Venice to Cedars. That's going to be my first chapter of my book. It's called Denial, It Ancient River in Egypt. I had a heart attack, a very mild heart attack, and I could have died, but I didn't. And when I didn't, I decided this is going to be a major wake-up call for me, because I had to reassess all that was going on in my life. I mean, I was always in good shape, I ate healthy, so I really don't fit the typical mold, but my life was steaming with stress, and frankly, I wasn't tolerating my stress really well. So I became known as this thing called a medical advocate, because I really advocate. I want you, your patients, your family members to take control of their health, because that's what I had to learn how to do. I mean, I was totally clueless. I mean, I didn't even think these symptoms were of anything, to me, I was out there. So it's learning about yourself and how to be your own best medical advocate. So that's what I do now, and that's how I kind of I was given that name. Okay. I like to start off with definitions. I love this one. Actually, I borrowed this from Dr. Weitz a few weeks. I couldn't believe it when I saw this. This is from Wikipedia. It's a form of alternative medicine, a number of unproven and disproven methods and treatments. Proponents claim that it focuses on the root causes and we develop an individual treatment plan. Opponents have described it as pseudoscience, quackery, and its essence a rebranding of complementary and alternative. I mean, can you believe that this was actually in Wikipedia? I don't know if you know how Wikipedia is put together, but I couldn't believe it. I was appalled. So I found something else that I thought was a little bit better. This is a definition from Jeffrey Bland, who's thought to be one of the fathers of functional medicine. I like this because it says the vector of change in time is determined by the unique interaction of its genome with its environment and so forth. Because you know what, we're not static, we're always moving. The world is moving, we're moving. So I really like this definition. I think that kind of explains what we all do here in functional medicine. Sorry, one more second. Went backwards here. Yeah, okay, I'm going to go back. One more. Excellent. Okay, so then with integrative cardiology, I didn't check out Webster's. I made my own definition. That is going above and beyond, going outside the box, doing more than what's usually done in cardiology so that we can really help our patients. That's kind of how I describe it, what I shoot for. We all know that heart disease is a disease of excess. Excess body fat, excess sugar in the diet, excess the wrong kind of fat in the diet, excess blood pressure, excess smoking, excess stress, and a lack of one thing, and that's physical exercise, physical activity. And the major players, so we have to look at the risk factors. I kind of divide them into the major risk factors and the minor ones. Now the major ones have been unequivocally shown to be associated with heart disease. So hypertension is always number one on the list. Why? Because it's proven to be a major risk factor, not just heart disease and stroke, but also kidney failure, heart failure. And now it's been shown in recent years that uncontrolled or poorly controlled hypertension in middle age actually is a forerunner for dementia. So it's very important. Now, about 70 million people in this country have hypertension. Most of them either don't know it or they're not adequately treated. This is one risk factor that I'm adamant about treating. Not necessarily with medications. I always do lifestyle first. But whatever it takes, I think you really need to get the blood pressure down with the evidence that we have. So now look, the guidelines have changed. This is the old guidelines a few years ago. But things changed with the SPRINT study that came out in 2015. This was established in 2017. So now, ideally, if anything above 120 is considered borderline. When I was a medical student 40 years ago, 140 was considered borderline. Now it's anything over 120, so we really have changed. And now, as far as hypertension is concerned, if you're 131 over 81, you're hypertensive by today's definition. We all need to keep that in mind. Because most doctors really aren't, the traditional doctors really, they let their, I see patients all the time with 140, 150. My doctor said it's okay, but it's not okay. And first when these guidelines came out, I would say, okay, it's just like a wet ring plot for us to buy, for patients to take more medications. But actually the data is real, that people that have a normal blood pressure throughout their lives do better. And I can tell you from my 33 years of practice, the people that have blood pressures in the 120 to 70 range do better. They have less heart attacks, they have less strokes. So people ask me, what's the ideal blood pressure? I don't care whether 20, 30, 40, 50, 60, or 100. It's still gonna be the same, 120 over 70. Doesn't mean I aim to get that with every patient, but that, because I individualize my therapy, but these are things I really want you to know. Smoking, what can I say about smoking? That has been said. It's the most preventable risk factor of all. But I think we sometimes forget that smoking is not just a risk factor, it's also an addiction. And some people can quit when they have a heart attack or stroke, and some people can't because we're dealing with addictions. So I look at it as addiction, and I think things like Nicotine Anonymous is something worthwhile. They need to be in a group situation in which there's only one desire, and that desire is to quit smoking, like an Alcoholics Anonymous desire to quit drinking. I think that's a support group that people need. I'll use whatever's necessary. I've used Chantix. There's other things that I use, and also it's different forms of biofeedback can be really useful. But we have to get people to quit smoking. It's really a problem today because the younger people are smoking all these flavored cigarettes. It's really terrible, and these things are really not good. Cholesterol. Okay, we've all heard about cholesterol. It's been one of the original 3 major risk factors since the very beginning. But I look at cholesterol as part of a continuum. Let's look at the size. Is it large, buoyant, or large, fluffy, or is it small, dense? And we're going to get more of that into the laboratory testing, but certainly the LDL always stands for lousy in my book, and HDL stands for healthy. But it's not all that simple. It really depends on the size of the actual particle. So large is more favorable than small, dense, and we'll get into that. Physical activity. I think it was the early 90s when this one was elevated as a major risk factor, which I thought was really nice because you have to remember only 20% of the American population exercises on a regular basis to achieve what we call normal exercise in American College of Sports Medicine and the American Heart Association. And that's about 150 minutes a week. It's really not that bad when you break it down. So it's not exercising at all. It's as bad as smoking cigarettes. They've actually made that kind of comparison. Obesity. Now, years ago, they just figured, well, if you're obese, you have more likelihood of being hypertensive, you have more likelihood of having bad habits, and elevated cholesterol and triglycerides. But obesity now has been shown to be an actual risk factor in itself, above and beyond. Then diabetes. I don't think this is surprising to anyone. Diabetes is an inflammatory disorder that's highly associated with heart disease. You've got to remember that over 70% of diabetics will have either a stroke or a heart attack in their lifetime. So it's a major risk factor that needs to be treated. Then we get into the minor league, I call it. Now, these risk factors have definitely been shown to correlate with heart disease. However, the magnitude of that correlation is still a bit controversial, so we call it the minor risk factors. Elevated triglycerides, for example. Now, we really think triglycerides is a risk factor for heart disease itself, but I can tell you one thing, even if it wasn't, elevated triglycerides is like not a good thing. It tells you that there's a metabolic problem going on, okay? Usually with elevated triglycerides, you normally will have low HDL or dysfunctional HDL, which is a protective cholesterol, and also you have fatty liver. So a lot of things happen with elevated triglycerides. So I look at it as a metabolic problem, which is obviously does have a heart connotation as well. Elevated Lp(a). Now, Lp(a) you've heard of, that's a fragment of LDL. It's highly inflammatory, it's very sticky, and it has been shown to be an independent risk factor for heart disease. Most doctors don't draw it because they don't know what to do with it, because there's no medication out there that will clearly lower it, and statins don't lower it, exercise doesn't lower it, change in diet doesn't lower it, but it is genetic, and I particularly am interested in this in younger people that have heart attacks, to see whether or not the Lp(a) is elevated. Elevated homocysteine. It's funny, I was treating homocysteine before I even knew about MTHFR. I thought MTHFR was some kind of profane, label that they gave this weird enzyme. Anyway, elevated homocysteine is also a risk factor. Again, doctors don't check it because there's no drugs that we have to use that we can use that will lower it, but there are supplements. So basically, your body wants to break down homocysteine to cysteine thymine, but it can't do it because of this enzyme defect, which we now know is highly genetic, and we can determine that. It's so easy to treat this. I check this on all my patients. Elevated C-reactive protein. I can't imagine why traditional doctors aren't doing this on all their patients. It's clearly a risk factor for heart disease. The 4 big ones, talking about heart disease, cancer, autoimmune disorders, which are clearly on the rise, and Alzheimer's. They all have one thing in common, that's inflammation. So we have to take inflammation very seriously. And I put this right underneath it, periodontal disease. And I am really bugaboo about this. When I see patients that have persistently high CRPs, and I mean levels of 4, 5, and 6, then I decide, okay, we have to determine where's it coming from. Because you really can't just treat it without knowing that. The number one place is the mouth, the oral cavity. There's no question about it. And I recently found out that your average dentist really doesn't know how to check for this. I used to say, okay, I check the value and give it to the patients. Here's your, go to your dentist. And they come back saying, my dentist says I'm fine. Then I send them to, now I'm sending them to periodontists, someone whom I really trust. I have a couple on the west side that I use and a couple in my area. And lo and behold, there's a lot of disease in the mouth that was missed by your average dentist. So it's really important. The other big source is probably the gut. we know that. And so these are the two things I look for. Number one, in people with persistent levels, is the oral cavity and the gut. There are other inflammatory markers. Fibrinogen is also a non-specific marker like CRP. Doesn't tell you where it's coming from. It's an active phase reactant. It's made by the liver. It's essential for life. It's one of it's clotting factors. But when it's elevated, other than in the presence of an acute infection, it's also kind of another source of inflammation. Lp-PLA2 is an enzyme, and that's more specific for vascular inflammation and unstable plaque. So when you see that in your patients, you have to really think about heart disease. And MPO, which is myeloperoxidase, is actually something that's released from white blood cells, again, during inflammation. So I'm bringing this to your attention so you can just notice that these are things that I think should be examining your patients. There's the genetic markers, so really getting genetics on. These are some of the early ones, ApoE, KIF6, which has been shown to correlate with coronary disease, and also that's one that you might want to actually use a statin, because people with statins actually it improves there's actually some evidence that it can decrease the rate of coronary events. 9p21 is another one. I don't know who named these things, but it's based on the 9th chromosome. There's another one also that I don't have here, 4q25, and the patients with that one tend to have a higher propensity of familial atrial fibrillation. And I've checked on some of my recent patients. I get about 3 or 4 atrial fibrillations new every month. That's how common it is in a solo practice. And now I'm checking this, and I'm seeing frequent, positive gene markers for this. Environmental pollution. What can I say? I think we're all beginning to understand how this does play a role. And here's a big one: stress and depression. Now, at the time of my heart attack, I had normal blood pressure. I had a good cholesterol profile. I'll share it with you in a minute. I've never smoked. I've never been overweight. But I had a lot of stress. And frankly, I wasn't dealing with my stress very well back then. And that was my wake-up call. I had to, that's when I started my own meditation practice. I did a lot of things that I do to this day to help, to package my stress, because stress is rampant today. We're living in stressful times. Okay. So now let's talk about advanced cardiac testing. Why do we even want to do it? And I'm going to introduce some slides from Boston Heart, because they do such a good job of laying this out for us. I am a paid speaker, so I do mention that here. The challenge is, and I love this, so despite all that we've done all these years with heart disease, it's still the leading cause of death in the United States. So a third of people in this country will die of a heart attack or a stroke. And then the cost is enormous, and 50% of patients that have had a heart attack have normal LDL. I was one of them. Have a normal cholesterol profile. Here's another reason why we have to go above and beyond, because 50% of coronary disease diagnoses, 50% of coronary diagnoses are occur at the time of sudden death. So I always tell patients that if you make it to the hospital in time, it's a good chance you're going to make it, because we're going to throw you in the cath lab. That's when you want your rest of medicine. We're going to throw you in the cath lab, and we're going to try our best to open the artery up. That's what we call our STEMI call. But 50% of people are not making it to the hospital on time, and they die at home. And that's why I think it's important to do this advanced cardiac testing. And most patients with coronary disease do not have a classic lipid disorder. Again, that was me. And most people with statin have an event, more than the numbers that actually prevent it from having an event. So they still are having events. It's not just about statins, although you would think that's how it is in this country. And it's a family disease, and that's why I think the advanced testing is so important. Now, this is my profile about a year and a half before my event. Now, look at this. My LDL was 79. My total was 126. This is normal. I even did an LP the other way, even though it was back then, 17.9. So, kind of strange, right? I had a totally normal profile. So when we look at the risk factors, okay, and this is what Boston Heart does so beautifully. Yes, I want to know about the cholesterol. I also want to know about the metabolic picture. I want to know about the inflammatory markers and the genetic markers. We've already alluded to them. So let's look at the cholesterol. This is how a typical pattern will look, and with Boston Heart. So of course, green is good, yellow is caution, and red is like not so good. So you can see this person's panel is not bad. Total cholesterol is slightly elevated, but the LDL and HDL are certainly okay. But they have an ApoB of 130, and they have a small dense LDL. Now how Boston does it is this. By Quest, which brought out Berkeley Heart Lab, which actually measures the size of the LDL particle, and they measure it in angstroms. Okay, how Boston does it, they do it a different method. They're actually determining the concentration of small dense LDL in the sample. So you want it to be as small as possible. You want it to be less than 20. This person is 38. So already from this panel, that looks pretty good. Traditionally, you have an elevated ApoB, and you have a high small dense particle size or concentration. So why is ApoB so important? Because ApoB tells you more than LDL. Like here you have an LDL of 100, here you have an LDL of 100, but the ApoB is significantly different. And it's up to 70% more particles you can have. So we do look at that. There's some important studies that came out that really look at ApoB. The ASCAP study and show that ApoB may be a better predictor than standard LDL. The same thing with the Amoris trial. But forget about the trials. This is what I think is the important part. Both the American Diabetic Association and the American College of Cardiology have supported utilizing ApoB as part of the workup. Now, do you know many cardiologists that order ApoB? I don't. Even though it's been endorsed by our specialty society. Now let's look into a little more. This is the same patient. The ApoB here is 130, so this is the same thing. Actually, it's just a magnified view of the same thing. But let's look at the small dense LDL. Small dense LDL predicts cardiac events independent of LDL. You can have a normal LDL, and you can have a large amount of small dense, and that is a definite risk factor. It's superior when it comes to predicting events. It's associated with new lesion formation. And here's what you got to know. The reason why we worry about small dense is that it's 30% more likely to cause oxidation of LDL. So part of it is I don't care what your LDL is or even your total cholesterol, but I do care if it's oxidized, because that's going to be the forerunner of inflammation. And that's the problem when we're talking about small dense LDL. The propensity for oxidation is 30% greater. So it's a big deal. Same thing. Here you got two major organizations, American Diabetic Association, American College of Cardiology, back in 2008, support utilizing small dense LDL as a risk factor. I mean, in my area, I don't know any cardiologists that orders it on a regular basis. And yet it's been endorsed by our specialty societies. Okay, then we go to Lp(a). Now, this is a different panel. The LDL is a little, it's all borderline, but now we have Lp(a) of 135. The normal is less than 130. So, again, you can exercise all you want, you can have the best diet in the world, and usually it's not going to take care of Lp(a). And when we get into treatment, I'll tell you how I deal with it. But it is important to note, that means we have to be really mindful and careful when we deal with all the other risk factors, because this is one you can really control. Then we look at how cholesterol is actually metabolized, or lipid biology. And basically, there's three things you need to know. First of all, most of us are going to get cholesterol in our blood from the liver. The liver produces it. I don't care if you're a vegan, your liver is still going to produce cholesterol. Why? Because it's essential for life. You can't live without it. It's that important. So that's about 75% of us use our liver as a means of producing cholesterol. About 25% is from intestinal absorption. And then you have the remaining from this thing called LDL receptors, which I'll talk about in a second. So this is a great slide. I like it. So here's what we want. We want the production and the absorption to be, it's kind of tipping in one direction. But what Boston does, they actually measure markers. We have methosterol, demonstrol, and then we have these other markers here. These are markers specific for production, and these are markers that actually predict absorption. And I'll tell you how that's helpful, because they have what's called a cholesterol balance test. Okay, so this particular patient, you can see the production is way over it's way out of line. Yet the absorption markers are low. And that actually is kind of a useful thing to know, because how do you treat these patients? These are patients that statins do work, and they work quite nicely. Red yeast rice supplement are very good for these. Niacin could work. So, but it's nice to know what the problem is before you can decide to treat it. Here's a different patient. This one, the production markers are low, but the absorption markers are high. Going up on a statin is not really going to help the patient overall. So what can we do here? Well, there's a medication called Zetia, which is accessimide. It's generic now, which does help with hyperabsorption. Also, berberine can be very useful. Eat about 1,000 milligrams or more a day. And also, probiotics are also useful. So there are things that we can do before we even go to medications to work on the production side. Also, artichoke extract can be very useful. So this is a composite slide that I had Boston make for me. I kind of put it together. So this is what we do if we have hyperproduction. We have statins, we have red yeast rice, we have citrus bergamot. And then we don't really use much bile acids and courses anymore because patients hate it. They were around forever. They cause constipation. They taste terrible. You have to mix it in water. They're not very popular. I haven't used them in years. And then here we are on the absorption side, okay, systemide, which is Zetia, berberine, artichoke extract, and also probiotics and soluble fiber. Now, the LDL receptor has got a lot of attention lately because in classical cardiology, traditional cardiology, we want to just get lower. Lower is always better, right? So, I mean, now they want to add statins and this new thing called a PCSK9 inhibitor, which is a biologic that you inject subcutaneously twice a month. It's outrageously expensive, and it definitely works, and because you want to upgrade LDL receptor function. But look what can downregulate it, and this is really important because I think you've noticed that your patient that is clinically hypothyroid, you're going to have high lipid levels, just because it's the downgrading of the receptor. Familial hypercholesterolemia, which is one reason why these new drugs came to be. I have a few patients that cholesterol is like 400, LDL like 250, close to 300. Those are going to need something special. Your diet's not going to work for these patients. And also fatty acids imbalances. Obviously, trans fats are the worst, but also this is one case in which I get a little concerned about too much saturated fat, because that can downregulate the LDL receptor. This is kind of a nice little picture. So these are the receptors, and they go right through the liver the cell membrane. They want to capture these lipid particles. So as long as you have enough receptors, they're going to capture these lipid particles and get rid of them. The problem is when they're downregulated, you have less receptors, and this is a normal function in our liver. So that's the whole PCSK9. And by the way, berberine is a natural PCSK9 inhibitor. Your knowledge. Okay, then they also have this called a fatty acid balance test. I really like this test because it tells me what's happened like the last couple of weeks with regard to the fat intake of a particular patient, and it's really important to see how they're absorbing, if they're taking or making 3 supplements, and also reveals potential downregulation of the LDL receptor by decreasing clearance. So this is how this looks. Of course, we always want the trans fatty acids to be as low as possible. That's in the green, that's good. This is saturated fatty acid index. I don't really look at that too much because I do not believe that all saturated fat is like bad for you at all. But if I'm having a clearance problem, I might want to look at that later down the line after I've tried various things. But it's not what I look at first. I kind of ignore that. Obviously, I care about the omega-3 fatty acid enzymes in both the EPA and DHA. You can see this patient needs more supplementation. The other thing, and this has changed, this is confusing to me, but this monounsaturated fatty acid index I thought was great because it told me what's happening with the monounsaturated. Because I always thought that the higher the better, right? You're talking avocado, it's olive oil, and they've changed it. Now they're saying there's controversy. Boston has said this, and I haven't gotten the latest word. There's controversy as to whether polyphenols are really good or not. Now, I don't know. I don't buy that yet. And so what they did down here, see, nothing here is color coded. These are the controversial section. That's why nothing's color coded down there. They have moved that down to here. This is an old slide. They moved that down to here, which means that was controversial. What they used to call optimal is now bad. So I'm not buying it yet because it's based on some meta-analysis on one major study that was, I think came out in in England, or the Lancet, British Journal, a few months, I think in the fall. So I have to stay tuned for that one. I'm still using olive oil and monounsaturated fats. I think they're basically very healthy. And then we also look at the healthy cholesterol. Okay, so again, bigger is better. Whether it's LDL or LDL, bigger is always better. So Boston does it differently. They look at alpha 1 and alpha 2. You can see there's 5 major particle sizes. Bigger is better. So you want higher alpha 1 and alpha 2, and you want these to be as small as possible. Now, you probably heard from other labs, HDL2B, that would be what you would basically say for alpha 1. So here's how they do it. This alpha 1 is not so great. Alpha 2 is optimal, but look, these particles are way bigger than they should be. So this person has dysfunctional HDL. So it doesn't really matter what the HDL is. It's dysfunctional, it's not really protective. And that's important to know. Metabolic, this is the fun part. These are all the things we're getting from the metabolic. A1C, the glucose, insulin. I'm going to break it down in a minute. So this is one of my favorite things. And so, okay, the A1C tells me how well the blood sugar has been controlled for the previous 3 months. It's a marker on the red blood cell. HOMA-IR is homeostatic model of insulin resistance. So it gives me an idea of whether the patient is prone to insulin resistance or not. Because you can have someone with normal A1C, as this person does, and you already have HOMA-IR in the red zone. If you look down here, look at the insulin. 33 when it should be less than 7. Less than 5 in their book. So that's really high. Yeah, the A1C is normal and the C-peptide is normal. C-peptide is a test that tells me how hard the pancreas is working. So if I see the C-peptide being elevated, I tell the patient this is not good. Because if you run out of insulin, which is what that's telling me, then you may become an insulin-hard diabetic one day. So it's important that you know this so you can tell your patients this. This gets them moving, hopefully. And then GSP is another test. I don't really use it much. It tells you how the blood sugar is controlled for the previous 2 weeks. Doesn't do much for me. And the adiponectin is interesting. And that's a hormone that's excreted by actually healthy fat cells. And it protects against both heart disease and diabetes. You want that to be as high as possible. And this person is 7.5. You want it to be greater than 10. So, and adiponectin, by the way, can change. So, again, it's always the same about lifestyle. It's diet, exercise, and weight loss, no matter what we're talking about. Niacin may help that as well, but niacin can also increase your A1C. And then these are blood pressure medicines. I don't like these drugs. Then, of course, fish oil is always useful. Inflammation. Now, I tell my patients point blank, part of me says, I don't really care where your cholesterol is. I mean, I do, but I don't. But I do care if you have inflammation. And that's really, okay, whether it's heart disease, cancer, autoimmunity, or Alzheimer's, we all have that one thing in common. And I love the way they do this. So here you got a fibrinogen that's elevated, the CRP's off the wall. Yet these are your vascular markers for inflammation. And these are in the green, which is good. So it's probably extravascular that's causing the problem. But it tells where. And that's where the functional medicine part comes in. So why do I care about this? Because this LP-PLA2, which is one of those vascular ones, I like this very much because this is your necrotic. This is what a plaque looks like. This is a stable plaque. You have a necrotic pool here. You have a nice, thick, fibrous cap there, and that helps protect that from rupturing. All of a sudden, this has become very necrotic, and you have a very thin, fibrous plaque. You have the beginning, and here's the rupture right there, and then you've got a blood clot developing. And that's what happened to me. I didn't really have, I had like a 40% blockage, but I had a huge blood clot. I wish I had pictures of that, but so that's what it takes, a stable plaque into an unstable. When you have an unstable plaque, that's the bad part. And we don't really know. That's why we have to use all these tests as good groundworks, because it's not a special test that says, oh, you got a stable plaque, no problem, or you got an unstable plaque. That's why we need all this information as ammunition to help guide our therapy. MPO is, again, it's found in circulating white blood cells. It is released during inflammation, and statins can help it. But again, it's an inflammatory marker and it needs to be looked at. And these are the things that can cause falsing elevations, infections, inflammatory bowel disease, myeloproliferative disorders, kidney disease, heart failure. There's a whole list here. So if your patients have this, you can't really look at MPO. but the LPPLA2 is another useful vascular test. Okay, genetic test. Now, I'm interested to see what Boston comes out in the future with some of these genetic markers. Things are changing all the time. But this is unique to Boston Heart, this slope code gene. And I really like it because it tells me if a person is it has to do with if they're more prone to statin-induced myopathies, okay? Because you can be heterozygous, you could be homozygous, and this one's heterozygous. So that increases your risk because what happens, the statin is hanging around longer in the blood circulation. So that's when you have to worry about these aches and pains, which are the most common side effect that we hear about with statins. We're going to know that myth. ApoE is an interesting one. It tells us whether a patient is prone to developing premature heart disease on the basis of hyperabsorption. These people tend to absorb more so than people without that genotype. It's also a genotype for Alzheimer's, as many of you know, and I tell my patients that. They tell us you should tell your patients that. Of course you should. Because to find out, all I do is go to the internet and read about it. Then factor 2 and factor 5 Leiden are clotting factors, clotting tests. So if a patient has heterozygous or homozygous for that, it means they're more prone to blood clotting, which is important. You might want to put those patients on aspirin. And then MTHFR, which you've heard enough about. So they test for all these. And this is what's important about the slow code gene, because look, if you're heterozygous, it increases your risk of a statin-induced myopathy 4 to 5 times. If you're homozygous, which is a small percentage, but 17-fold increase. So when I see a slow code gene, do I ever use a statin? With caution. I may use like a water-soluble statin, like pravastatin or rosuvastatin, which is Crestor. If they're homozygous, I won't use a statin at all if I can get away with it. These are the patients that if they have heart disease, I would probably do the PCSK now. We'll talk about treatment after. Okay, MTHFR, I'm not going to go into much of that. I think a lot of you guys know as much more about that than I do, but it's made a real difference. Like I said, I was treating homocysteine way before I knew about MTHFR. So this is the variants that you can get with MTHFR. This is the normal pattern. By the way, 60% of people have one of these patterns in this country. That's how common it is to have either the heterozygous, one single copy of one variant or 2 copies. So it's very common, and it's important. We'll talk about that later. They also do some other general testing. This is your liver test. And they do NT-proBNP. So NT-proBNP is a new marker, and it lets you know if there's any cardiac dysfunction whatsoever. So you'll get elevated values in certain patients. If they're hypertensive, it's going to be elevated. If they have hypertensive heart disease, for sure, meaning hypertrophy of the left ventricle. If they have paroxysmal atrial fibrillation, it's going to be elevated. So I see in my practice a lot of these. It's a very sensitive. It's not to be confused with BNP. BNP is a marker for heart failure. It's not like it's just much smaller, a micro, kind of like microscopically what's happening. Also, what I like about this lab, they do the cystatin C. Cystatin C is probably the most sensitive test we have for renal dysfunction. I mean, like I have a lot of bodybuilders in my practice. So a lot of bodybuilders will have normal BUN, but they'll have a slight increase in creatinine. I'm one of them. My doctor's like always saying, you get a kidney problem. And I always do my cystatin C, and it's always way below, way normal. But traditional medicine, they don't know about this test. They're still not doing it. I had to explain to a nephrologist what this test was. Can you believe that? So I like the fact that this is automatically done for you with Boston Heart. And then, of course, it does your thyroid, vitamin D, and it does CoQ10, which I really like, because I think CoQ10 levels are nice to measure. It's easy something to give. So that's kind of rounds it up what Boston can do. So now the treatments. So this is where traditional medicine leaves off, right? This is where we come in and where they leave. It's about lifestyle. And it's always diet, exercise, weight loss. It's where we shine. So lifestyle, as far as, these are, let me just go down. Medications, of course. ECP, which I'll explain. And balloon angioplasty anesthetics. It gets worse and worse as you go down. And it's bypass surgery. Now, these are the ones that traditional medicine does a really good job on. But do all these people need medications? That's the question. I think that's not really. We jump to this, and we also jump to this. We jump to medications, and we jump to stenting. I mean, I go to a cath conference every 2 weeks in my hospital, and I'm seeing these 80, 90-year-olds going for balloon stenting and angioplasty. And it's crazy because there's other things you can do. You can treat. Now, so here's the lifestyle slide. Diet, exercise, and supplements. Diet. So, cardiac diet, first of all, you all know with the heart associations, they still propose the same diet they have for the last 50 years. I blogged about this. They came out in June, 2 years ago, 2017. The whole thing about saturated fat is bad, coconut oil is bad, canola oil was fine, olive oil was okay, but canola oil was just as good, and vegetable oil was fine. And this is the same thing they've been saying since 1965. And it's just, we know more, we know better. And this was a big promulgation that came out, and it went viral.
And it's not even just that vegetable oil is fine. Actually, soybean oil is preferred.
Yes. Yeah, it was just crazy. So, for sure, so that's why we talk now about the American heart diet of the 21st century. Because that diet was in the 20th century, and we learned a long time ago that it failed miserably. In fact, like in the 90s, when I was a young cardiologist, the diet was the Heart Association diet, and everything was low fat, high carbs. And what happened? The country got fatter. We have more diabetes than ever before. It's an epidemic. It's based on that diet. It's been a miserable failure. Yet, the Heart Association is still touting this diet. I don't get it.
And it's still basing it on the same studies from the 1960s.
Ben and I have reviewed these studies, and like the same studies are being quoted 50 years later. There's no new information. But that statement that went out 2 years ago, and this month actually, really hit headlines. So, Mediterranean diet, okay. I agree about Dr. when she spoke last month. I think it's a little too much carbs, but it has been studied, and at least in cardiology, it's been studied more than any of that, so it has withstood the test of time. Even though it may be a little more carbs than I like, it's basically a pretty safe diet. And again, like I said, it's been studied extensively. So I think people can do well on the Mediterranean diet with maybe some modification. Then we've got the Paleolithic diet. That's a real big one. There's 4 big diets that I see in my practice. So Paleolithic, basically, if it doesn't run the wall or grow on a tree or a bush, it probably shouldn't be on your plate. And it sounds really good. But the studies are really not that many studies. It's a burgeoning field, but the studies are small and of short duration. So I kind of like this. I'm kind of between paleo myself and Mediterranean, but there's a lot worse you can do. There's some people that say, oh, this is like a really dangerous diet. I don't get it. And we're talking cardiac patients. Plant-based vegan. This is a big one, okay? If you have, and see, you've probably heard of the Orange Plan back in the 90s when all this was going on. So he took patients, they didn't know about small deaths, they didn't look at triglycerides as a risk factor, they didn't know about, they were looking at fatty liver, they did pick sick cardiac patients, and they put them on a vegan diet, and they did, they had counseling, and they had a support group, they did some really good things, and they all did better. First of all, it was a small group, let's face it was not a large study, and it hasn't really been replicated by many other people. It's a very strict diet, and I've seen a lot of people on vegan diets. I have a daughter that's been on it. She's had tons of gut issues being vegan and being raw. And so it's interesting, and I've seen other people with it. There's certainly mineral deficiency, vitamin deficiencies. So I'm not against it, but you should be working with someone who really knows that diet well, because you need to have complete proteins. And if you don't know what you're doing, and you're not mixing rice with beans in a certain way, and I'm not an expert on this, you're going to have a lot of deficiencies. So it's a diet that really requires a lot of planning and to. Now, the ketogenic diet is really interesting. I know we talked last month about whether it's useful for cancer. It can be very useful in cardiology, not across the board. The ones that I have done, that I try to get people to do this, people with metabolic syndrome, Obesity for sure, they tend to go hand in hand. Diabetes, pre-diabetes, fatty liver for sure. Because you will get results. And I think putting it all together, all the things that I've read, I think having someone on a ketogenic diet, a strict ketogenic diet for about 3 months is probably safe. Okay, they should be monitored. And then after that, they can deviate. They can, I'm not into awful, terrible food restrictions because I think that can be harmful, So I think you can reintroduce certain things. You can cycle keto days with low carb days. I don't think you should do keto and then high carb days. I think you should do keto, which is strict, and you can have you can alternate with some low carb days, but not so strict. But I do find that can play a role in my patient load. But again, I deal with a sick population and a lot of metabolic problems. So there is a role for that.
I think one of the issues when it comes to diet is if you compare any specific diet to the standard American diet, they're always going to do better. And
Right.
there just aren't enough studies comparing one of these specific diets to the
But
other.
there is one study that I think...
No, yeah, there's a number.
Yes. Okay, so these are the trials that you probably have heard about. This one was the Women's Health Initiative. Okay, and that was your low-fat diet, less than 30%, less than 10% saturated. Okay, no effect on stroke or coronary artery disease. Okay, the look ahead was a smaller study, and it was actually closed because it was futile. They didn't get any positive results. But look, this is the one that made headlines, the Predimed study. Okay, it was a relatively large study, and they used high fat. Now, I don't call 40% really high fat, but it was higher than anything else that they've studied previously. And 4.8-year mean follow-up, and it was close early for a greater than expected outcome. But that was an important study because it did really help put no training diet on the map. And so I think cancer is different than heart disease, is different than, intervention. I always look at diet as to what's the goal, what's the patient, what is their problem, what are we looking to do. So with heart disease, I want to prevent further events. If they've had an event, like my plan for my health is never have a heart attack or stroke in my lifetime. One was enough. And I was very fortunate that it got me where I am today. So,
Howard,
I think that's about, let's see.
Howard, can you just comment
please.
quickly about
Please.
fasting mimicking diet?
Yes, okay.
I know you've got.
I was going to talk about that, but I will now. Thank you. So fasting, have everybody heard of fasting mimicking diet? Okay. Yeah. No, this is different. So fasting mimicking diet was proposed by Walter Longo. He's from Geneva. Not Geneva. He's from Genoa, Italy, and he's been at UCLA. Actually, he came to UCLA, but he's been at USC, and he heads the longevity center there. And so basically it's totally based on caloric restriction. For the first day, it's a 5-day diet that you do consecutively for 3 months. 5 days. So the first day you have 1,200 calories. On days 2 through 5 you have 700 calories. Doesn't matter whether you are Suzanne's size, my size, anyone's size, but it's your size, you probably wouldn't recommend it because there is a way you don't want to do someone who's really tiny. But it's been shown. The thing I like about it, I did it for the longevity aspect. There's some really good studies coming out as far as longevity. This guy has studied longevity. You should read the book, The Longevity Diet, and he's really done some good work. I have used it. I'm using it more. It's regimented. I do great with regimens. I can follow it to a T. But it's an easy diet to follow. You can get with this company called Prolon, you can actually get a kit, and the kit has 5 days worth of everything. So all the guesswork is out. Everything is planned for you. Some people don't like it because it is processed. I think basically it's some healthy stuff, but there's some things that I don't like. Like use folic acid. Use folic acid versus folate. And you can do your own, and they share in the book, but it's not easy because you have to match the macronutrients. And people that try to do their own, they actually undercut the calories. I don't want to have any less than 7 calories a day, believe me. So, but I think it's got promise. I like the diet. I've done it. I did 3 consecutive months, and now I do it quarterly, just to keep my system clean. And I feel great. When I'm in ketosis, the 4th and 5th day, it's not from eating too much fat, it's from caloric restriction. I feel great. My energy level is great. My mental acuity is, I'm less moody. I'm more pleasant to be around, I think. It's been, I've had a very positive response to it. But I always say there's never one diet for everybody. And It really depends on what your goals are and what your makeup is all about, you know. Let's see. So the only other treatment I want to mention, one thing is ECP, because people think there's too many angioplasties and stents going around this country and bypasses. So not just because I do this in my office, I think this is a great treatment modality. So what happens? And by the way, it was approved by the FDA in 1996 and by Medicare 2 years later in 1998. So you have cuffs around the calves, the quads, and the buttocks, and it's timed to your EKG, which is the machine here. The generator underneath here actually inflates and deflates these cuffs, like a blood pressure cuff. And they're done sequentially. You think they're done at the same time, but actually sequentially. And if you're increasing the flow of blood from the lower extremities centrally to your heart, and miraculously over a period of several weeks, you actually are building, the growth factors are released, and you're building new blood vessels. So why I like it? Because it's about 80% effective in improving blood flow and improving symptoms. Because one of the things I want to improve is symptoms. I want to improve longevity too, but if you're taking someone elderly who really is high risk for interventional procedures, this is a great thing for them, and it's proven in Medicare. So it's just, I just mentioned it because I think people should at least know about it. I did my office, but there's a center here on the west side that does it quite nicely. So it treats chest pain without surgery, blood pressure stents, medically, perfectly effective, easy and safer. I mean, there's no side effects whatsoever. It's painless, outpatient. Results can last for years. So usually, what Medicare, they usually will, there's 35 treatments. Each treatment's about an hour. It's pretty comfortable, actually. And it's Medicare approved. So medical advocates take the high road. So that's what I've done for myself and what I do for my patients. And now we'll open up to questions.
Anybody who wants to ask a question, raise your hand, and Keely's going to bring the microphone over.
Hi, I wanted to know if there are any extreme differences or anything that you can elucidate on the difference between men and women.
Okay, yeah. She asked if there's any difference between men and women. That's a great point. In fact, there was an article that just came out today. I don't know if any of you see it. I had a chance to scrutinize it. Yes, women are treated less seriously than men. They're taken less seriously, which really aggravates me. First of all, women present differently. Like, even I never really had chest pain. I had chest burning, then I had arthritis. You had to be a fool, then I think that's your heart, right? But with women, they tend to have really vague symptoms, like it could be nausea, it could be just weakness, fatigue. It could be, oftentimes they'll complain of jaw pain, pain in the teeth. So I have a little rule: if it's a woman and it's above the belly button, it's hard to prove it otherwise. But also, that's the diagnosis part. They've actually done studies in which women will stay in emergency room longer than a male before being examined. Can you believe that? They're not taking this seriously. And then also the anatomy is different. Women tend to have smaller arteries, so they have a lot of their symptoms is based on microscopic angina, which is, by the way, ECP works great for that. Because you can't really stent arteries that are really, really small, but you can improve the blood flow, which is what ECP does. So there are major differences, and that's a great point.
I'd like to drill down a little bit on supplements with you, Dr. Elkin. So let's start with red yeast rice. How should red yeast rice be used? When should it be used? What's the best dosage? What's the maximum dosage? Can it be used concurrently with statins? Are there other supplements that help it to work?
Good point. I don't take it with statins because they really are acting on the same pathway. We're working on production in the liver. So I often will start with that, especially in a lot of you gotta know one thing: most of the statins in this country are being prescribed to middle-aged women that don't even have heart disease. They're your biggest purveyors of statin medication in this country. Can you imagine that? And it's never been even shown in any study that treating these women with statins alters their prognosis. But if you want to treat, red yeast rice, usually I go up to 200 milligrams. I think that's the dose. I don't use it with statins.
It's usually 1,200.
Is it
400? Yeah.
Okay. Very bad numbers. So I usually start at the minimum workup. I'll go to the maximum dose really quickly.
Okay.
But I don't use it with statins. And
when do you have the patients take it?
Usually with their evening meal or at night. cholesterol is actually made at night when you're sleeping, and the newer statins like atorvastatin, which is Lipitor, and rosuvastatin, which is cholesterol, can be taken anytime.
So is it better to take it with the meal or apart from the meal in the evening?
But they do say with red yeast rice should be at night for sure, with dinner or before bed.
Have you used it with tocotrienols?
Yes. Yeah, it's a good product, I think, designed for health. I've used that product a lot. It combines those two together.
With CoQ10 also?
CoQ10.
CoQ10, definitely. I use CoQ10, well, first of all, I use it almost everybody, but I definitely use it if I'm going to put someone on red yeast rice or a statin, because that will help eliminate that problem with muscle weakness. What happens is that the pathway that the liver uses to produce cholesterol happens to be the pathway that the liver makes CoQ10. So CoQ10 is a normal material that we all make, a compound, but it's not made as much as we get older, but statins will definitely deplete you of it. So I automatically put someone on CoQ10 at the time of when I put them on red yeast rice.
So if somebody has a problem with cholesterol production and you put them on red yeast rice and you don't get the desired result, what would be your number 2 and 3 go-to supplements for that patient?
Well, first of all, I would definitely have done a Boston Heart or a study like that. It's going to tell me what the problem is it production, that would help. But if it's an absorption problem, we definitely have a different...
Right, so let's say this patient has a production problem.
Okay. I have used, I mean, you can use niacin as well, I would add. Niacin is not as potent as a statin in lowering LDL, but it will work. It works a little bit differently. You wouldn't just be acting differently. I mean, like I said, to combine drugs that do the same thing, it's not going to really be to an advantage.
Would you use citrus bergamot?
Citrus bergamot you can use. Yeah, citrus bergamot, definitely use a lot of citrus bergamot. Berberine is also useful, but more useful for the absorption side. But yeah, citrus bergamot, and you need to have, if you use citrus bergamot, the big number is you have to have 1,000 milligrams a day.
You showed a patient with unstable plaque. Are there specific supplements that we should use in that, or that you would use in that case?
Good. Well, got to remember that unstable plaque happens really fast. But when you develop an unstable plaque and you have a blood clot that's a ruptured plaque, these patients are going to present as an acute ischemic syndrome. So they're going to get attention right away. I can tell you they're going to be put on a statin and everything else. That's when Western medicine does really have to take over. But so we're really treating stable plaques.
Okay.
Now, so when you get
so you have a patient now who has a coronary artery scan, and they have plaque. Part of their arteries are, some percentage of clogged. Are there supplements that can reverse that blockage?
Motion has that question. I don't think, now there are some people, I do a lot of coronary artery calcium scans. I order a lot of those.
Can you explain what a coronary artery
so
scan is?
everybody know what a coronary artery calcium scan is. So what it does, it tells you if there's any calcified plaque in the arteries. And keep in mind, by the way, I had a scan done 2 years of my heart attack. It was a 0 score. To get calcium, it takes several years. But then I talk about patients, okay, you got a 0 score, but we don't rest on our laurels. You can still have fatty streaks because about two-thirds of plaque is soft tissue, and it's not picked up by that scan. Only the calcium is. But if you're a man over 45 and a woman over 55, it's a decent scan to get. But you can have someone like me who, you jump. So what do I do? Definitely red yeast rice. I'm going to start with that. Citrus bergamot's a good thing.
Vitamin K?
But now I'm using K2. K2, now there's a controversy between MK4, MK7. MK7 is longer acting. I use that one because I feel comfortable with it, and I kind of borrowed that from Dr. Steven Sinatra, who's a colleague and a mentor of mine. But you got to go high dose, and most of the doses out there are suboptimal. So I use one by Earth Molecular that's 180 micrograms. It combines K2, specifically MK7, with 5000 D3. And keep in mind, these studies on K2 that are coming out, which look really promising, are telling you about the endothelium. I haven't really seen any studies saying, oh wow, the calcium count's going down. We don't have those studies yet. But we think that a lot of this begins with the intact endothelium, kind of like the intact gut, right? It's very similar. So once that endothelium has been severed, that starts this whole inflammatory cascade. So, yes.
So on the other side, you have a patient who's a cholesterol absorber. What are the go-to supplements there?
Okay, I'll start with artichoke extract. It's inexpensive. Eat it about 1,500 milligrams a day. Probiotics for sure. That's about, you can lower your cholesterol level by up to 10% with probiotics alone. It's mostly the lactobacillus, by the way, that has that effect.
Soluble fiber.
Any soluble fiber will help. And there is a role also, even though citrus bergamot is thought to be useful in decreasing reduction, it does have some effect on absorption as well. So,
Now, what about plant sterols?
because plant sterols, I always use those, but now it's controversial whether plant sterols are really going to be helpful in this situation. I kind of put them on hold. What are you doing with them? I put them on hold because it's one of those controversial things now.
Well, one of the tricky things is when you look at the Boston Heart, they're measuring plant sterols as a measure of whether or not the person's a hyperabsorber. But I've used them and found them to be effective. So I don't quite understand, but
It's confusing.
What's the controversy? What's the controversy?
Whether it helps with decreasing absorption of cholesterol.
because if you look at a Boston Heart lab, they're measuring plant sterols as a marker that they're hyperabsorbing.
Yeah, that beta testosterone they're measuring, that's one of the sterols.
All right, okay.
So you're measuring, so,
I see.
it's just a little, yes, question.
Wouldn't a statin be better taken at breakfast time instead of dinner? Seems to be more effective.
Yeah, longer acting statins like the atorvastatin, which is Lipitor, or you can Crestor, which is
I
rosuvastatin.
would prefer Crestor than Lipitor, but wouldn't a statin be best applied for breakfast time in the morning instead of for dinner? It seems to be way more effective, or do you disagree?
No, the atorvastatins can be taken, doesn't matter when, with or without food, any time of the day.
Okay.
But the original ones like lovastatin and simvastatin were always taken with your evening meal, which is kind of like we are with red yeast rice supplement. Either with your evening meal before you go to bed at night. But the newer statins are longer acting, and you don't have to be concerned with that.
If you have a patient and you put them on red yeast rice and they don't get results, how high can you go? Is it
I go to the max,
beneficial?
I go to the max dosage.
Which is 2,400?
Yeah.
Okay.
They tolerate well. Same rules apply. You have to look out for the muscle weakness and pain. And also, you should check liver function, I think, because it still is a statin. I mean, the original statin, lovastatin, came from the red yeast rice plant. So that's how it was a botanical. That's how we, got into it.
You talked about the LP(a) particle. What nutritional supplements can be beneficial for that?
One that I have found that can really work is niacin. Okay, now I will tell you, you need to really amp it up. Usually these patients I often have them on maximal doses of niacin, maximal tolerable doses, which is 2 grams a day in divided doses. I use intermediate release, the immediate release ones, no one using more. I don't like the ones that you take at night, that's the pharmaceutical.
The timed release.
Yeah, because you wake up at 2 a.m. with flushing, and plus there are some liver abnormalities with it. It was called slow niacin was the name. There's another one that I used to use early on. I don't use the pharmaceutical brands, I just use the supplements, whether Metagenics or molecular. I use the intermediate release ones, and then I give them throughout the day, 2 or 3 times depending on what doses. But they don't work on everybody, but they do work on a lot of people. And with LP(a), I'll say, listen, we do the best we can. We may not be able to get that out, so we have to work really strictly on everything else. Yeah, there's one other thing I should remember we go on is that the PCSK9 inhibitors actually looks like they will have a role with LP(a). They're not approved for that, so we can't give it at this stage. It's a very expensive drug, but that may be something we see in the future.
And for those of you who are worried about the flushing, unfortunately, if you take the non-flushing kind, the inositol hexaniacinate, it's not effective.
Right. Yeah, you have to use the real niacin. Yes.
Thanks so much. Great talk. You had a case study here, and I saw, and it was a very quick, the vitamin D was super low, it was in the teens. And I've seen a correlation between increasing that vitamin D level, and when you do that, the CRP goes down, the diabetes markers, the sugar control's better, the inflammation's better, as well as cholesterol goes down. I'd like you to just comment on that, picture.
I think it's, I'm so glad you brought that up because they weren't doing D levels when I had my event. And so I really don't know mine was, but I can tell you that when I finally got it checked a few years ago, it was really bad. It was like 19. And because I've had a couple of skin cancers, I have to wear sunblock. So I was taking 15,000 units for the longest time. Now I'm down to 10,000. Cardiology, of course, doesn't really make they poo-poo any of the studies with D3. I think it clearly has an anti-inflammatory effect. There's no question in my mind. And I check levels on all my patients. And I try to shoot for levels of 60, 70.
I find that, if we can get it up there, 70, and of course you got to get the sun outside too.
Right.
But just with taking the vitamin D3, even some of my patients, I could do 15,000. Those CRP goes down. I mean, some people that are in 6 to 7s, it goes down quickly within 3-4 months, as well as some of the insulin, as well as A1C goes down. So it clearly works.
It clearly works. I don't know why traditional medicine has not caught on with this one yet. It's inexpensive. It's easily absorbed. I don't get it. It's not, I've never seen vitamin D, toxicity in my life. It's a fat soluble vitamin. I've seen people that have levels over 100 that I don't necessarily recommend. They've not had a problem.
And I think it's mitochondrial modulator that's where it works.
Right. So that's a good point. I think we're still learning about vitamin D3, but I'm a huge fan.
You talked about hypertension. What are your go-tos in terms of nutrition and supplementation? Is sodium an important factor? Other minerals?
With hypertension, first of all, it's always going to be diet, weight loss, and exercise. Those really are important. Exercise will help to decrease diastolic pressure and relax the arteries so that the heart can actually do more with less effort. So exercise is the key. I'm not major on salt restriction. I think it's been shown to not be terribly effective. Now, I think it's different. If you're talking about the African American population or diabetics, it may play a larger role, but in the average person, I don't really restrict sodium for hypertension. I think the important thing is the minerals that you need. You clearly need potassium. I don't usually have to supplement it because if you have adequate plant-based diet, you're going to get plenty in fruits and vegetables. Also, magnesium is also useful, and also a little zinc is not going to hurt. So you really should be able to get with the minerals and diet, weight loss, and exercise. So I try not to use medications, but I get people that really have heart, that truly are.
There's the DASH diet.
The DASH diet.
Yeah.
I'm not a big fan of it. I don't really use it. I try to be really simple with these patients because most of them are so out of shape, and there's especially the population that I see in Whittier. So with that, I don't think you have to be as regimented with diet as you do with like cholesterol and fatty liver and things like that. So I don't use a DASH.
So you mentioned minerals. I know magnesium is a natural ACE inhibitor.
Right.
Are there other nutritional supplements that play a direct?
Everybody gets CoQ10 and fish oil.
What dosages?
CoQ10 probably no less than 100, probably 200 milligrams a day. I use large doses of CoQ10 in patients that have left ventricular dysfunction, like cardiomyopathies. I'll go up to 400 or more a day. And again, Boston does do levels, so I'll look for levels of like 4.5 to 5, which is really high. But in someone who's got a cardiomyopathic heart, it's really useful. But for hypertension, since they're not going to have normal hearts, I would go 200. And for fish oil, I would probably do, if good fish oil, probably about 2 grams a day. I don't think necessarily more unless I would start off with that and see how we do.
What about hawthorn berry?
I don't use a lot of hawthorn berry. I think it can be useful. Again, I kind of pick and choose my supplements because it can be kind of overwhelming, especially if someone who's not used to supplements.
You see that a lot in these combination formulas designed for hypertension.
Yeah, I do have my own formula, by the way. After they call it pressure-wise, in which this is where I have had success in. The success has been in, it's olive leaf extract, Again, you have to have a decent dose of 1,000 milligrams a day. So it's not olive oil, it's olive leaf extract. It also has anti-carcinogenic properties, and it's also antioxidant, but it can be useful in decreasing. It doesn't work in everybody, but I've had several patients that with mild hypertension that it has worked. So that's one thing. I've done that over, it has also grapeseed extract and quercetin, a lot of anti-inflammatory. So I've had pretty good luck with that one. Yes.
Hi, Darren.
Oh, sorry.
So nice to see you. Do you know of studies, because I'm listening to people now talking about plaque and arteries. I've been hearing from at least 3 doctors now that there's a connection between high ferritin and plaque. Do you know much about this?
Yeah, ferritin is thought to be another. I didn't have it listed because we're just kind of getting to know that now. I do check ferritin. I forgot where the Boston checks it, but I do check it on my patients. High ferritin levels it's not a good thing. You know, as far as the studies that have proven it to be a component of heart disease, I'm not convinced yet. So the jury is still out, but it's something that I do check for. What would I do about it? You can see also high ferritin is also consistent with high inflammatory states. I say it all the time. So again, these patients also usually have elevated CRP, elevated fibrinogen. They're not in good shape to begin with. So
Yeah, iron is really like a heavy metal.
Yeah.
And they're all very inflammatory. So
Right.
even though you need adequate, stores of iron, it's very important. But excess iron, which is why most multivitamins for men and most menopausal women don't usually contain iron, because excess iron is inflammatory.
So I've been reading this book, Dumping Iron, How to Dish the Secret Killer and Reclaim Your Health. And I don't know much about this author, but I've spoken to a few different doctors regarding high iron.
Yeah.
So if I can't give blood, that's one of the obvious ones to donate blood. And if I can't do that unless I put port in, do you have any recommendations of lowering the iron other than giving blood?
You know, the classical way of doing it is giving blood or chelating.
Why would you have excess iron?
Why?
Yeah, to be the more important thing.
Well,
Is it you have hemochromatosis? Is that what we're talking about?
I don't know.
Oh.
How is
That's an easy
Isn't
test.
it often found with fatty liver?
Right.
Howard.
That's right. The fatty liver is very common. And by the way, to have fatty liver, you don't have to have levels that are off the wall. If let's say your ALT normally is like 25 to 30, if you start seeing numbers of 35, 40, and also do your GGTP, which is not generally included, and if that's elevated with it, then you pretty much, you can do an ultrasound, but if it's the right person that looks like metabolic syndrome, it probably is. And then you would see high ferritin. I usually see it in inflammatory states. As far as I guess I look at it as a big picture as opposed to just an isolated problem.
And
Yeah,
did you
non-alcoholic.
mention something earlier about when you take niacin that you could elevate the A1C?
Yes, niacin can elevate your A1C. So, and I have patients if they're frank diabetics or on the edge, I'll say, listen, we got to treat the diabetes first. We got to get you out of this metabolic state because you will do better. These patients probably need niacin more than anyone else. But it's very good for decreasing triglycerides, improving HDL, and decreasing Lp(a). I mean, it has a myriad of positive effects, but it can, I've seen it really improve. We know someone in this room who has had this problem. Yeah, it can really increase the A1C. So you have to follow that when you put someone on niacin. So if they're a frank diabetic, I'll really try to work on the diabetes first or the metabolic syndrome, and then add niacin later.
Okay, thanks.
Yes. I'm sorry.
Their question is there a problem with statins and berberine having a negative interaction?
Not that I know of. I've used them. They work. Who asked that question? I'm sorry. No, they work totally different. Statins work mostly for the liver, so the thing is concerned. Berberine is working also on the gut, to help decrease absorption. By the way, also it's useful for sugar, decrease the sugar, and also it's very gut friendly. You need bigger doses for the gut. But, so I'm not aware of an interaction. I don't see why you can't use it too.
What's the symptom what was the symptom?
Yeah, have you read your section about it? Have you read anything negative about the interaction?
Yeah.
You have? Huh. I haven't heard. So you can supply me with a reference. I'll get back to you on that. That's good. I mean, it's news that I haven't heard, but appreciate that.
So you were making a comment about niacin and then diabetes. So what if they're just pre-diabetes? Would you still treat the metabolic part first? That's one part. So this is a diabetes question.
Right.
Because you're also talking about, because diabetes is also a risk factor. And then you're going through the different diets because I would think, because you use keto for diabetics, but I've used it and then I feel like
it's a good choice. It's an option for them.
Oh yeah, for sure. And then, then potentially their cholesterol changes like in a negative way. So it's kind of hard. So then some patients are vegan, and then it helps their cholesterol, but then their blood sugar gets worse. So
Okay.
I'm not sure. Is there a priority? And then if they're just pre-diabetic, sure, use niacin.
Well, it's not necessarily the case that everybody who does high fat.
Right.
Oh no, I don't think so. I'm just saying I have patients in those. So is there a priority?
There's also an issue if you do keto and you start keto, sometimes you see an initial rise in lipids, and then if they do it for a longer period of time, it'll settle down.
And I should mention, with ketogenic, when you do your lipid panels, you kind of probably see the LDL go up initially at first. I don't really worry about that unless, I almost expect it, but you almost always see the inflammatory markers go down. Net triglycerides will go down. The liver enzymes will go down. So you got to look at this as a continuum and, what we're really trying to help here. Because there's good and bad to everything. That's why I always said there's never one diet for everybody. We have to individualize it.
And there's good and bad ways to do every diet. There's good and bad ways to do a keto diet. You can do a keto diet and have lots of green vegetables, and you can do a keto diet and just eat bacon and cheese and eggs.
Right, keto diet, people sometimes think it's like akin to the Atkins diet. It's really a moderate protein diet. It's not high protein. And fat isn't like eating garbage fat. You can choose to do that, but I don't think that's what is really recommended. And it can be highly plant-based as well. So I really suggest working with a person who knows that diet well if you're going to go keto, because it's very structured, but it's very doable too.
I think that, talking about the diet is one thing, but you really got to take a look at the microbiome and what are the bacterial content, your diversity, all of that really plays into the role of inflammation in the body, which of course then is...
That's a really important point, because we know that there's a gut-heart connection, there's a gut-brain connection. I mean, I didn't know any of this stuff until I really got into the functional medicine anti-aging field. And everything emanates from the gut. So it's so exciting to be practicing now, because we're really at the tip of the iceberg. We're learning all this stuff. But everything we order, right, Christine, we order stools on everybody now. I never realized that I'd be looking still as a cardiologist, but it's important because we see a lot of people with autoimmunity and people that have been to many doctors and they have fatigue and depression, and no one's ever looked at this stuff. So it's exciting to me to be practicing this and open up my arena to new things. So thanks for bringing that up.
Yeah.
In terms of what? Oh, which stool test do you like, Howard?
Well, I'm kind of gravitated thanks to you to the GI map. We used to use the Genova. We like the Genova as well. What would you call it?
GI effects.
Yeah. But I got new to reading. Christine does most of my office, but I like it because I like the autoimmunity. It tells a lot of information about just not just the pathogens. It's easy for me to understand. Not having a real background in that, it's kind of new for me. But I like pointing to autoimmunity because I'm getting to pick it out. This person's got an autoimmune problem. I've seen someone came in with vasculitis, one of my cardiac patients, and she's seeing all these doctors. And we did her gut, and lo and behold, she had a lot of things going on in there, pathogens as well as autoimmunity. And she went to UCLA. They do now. She went to a great doctor rheumatologist at UCLA. They do nothing about the gut. They do nothing about the stool. They do, well, they do put her on methotrexate. Which is, hepatotoxic, potentially so.
I think the combination is great. The genetic
Definitely.
GI effects, if the patient is willing to pay for it.
Right.
The combination, because each one of them really gives a specific key.
Yeah, you've had some really good experience with GI effects, right?
Yeah, both, but together, you really just take it another notch, because the GI effects, you get a lot of the functionality of the gut, and looking at the diversity of the different types of bacteria, and even the bacteria that are considered LPS producing, the gram-negatives, you can see a great deal there. It's not great for parasitic, but in my practice, I see a lot of parasites. So doing the GI map is where you're going to really zero in on the parasites. This is a PCR test,
Right.
and you'll be able to find the DNA of it. Although it's not like 100% foolproof,
Right.
but I think the combination, you're going to get the best of both worlds.
Good point. Thank you. That's great.
Okay, I'm going to sneak some questions in here.
Oh, good.
Okay, one question is along those same lines. How are you picking up the autoimmunity on the stool testing? That's one question. The second question is, what supplements do you recommend for someone with a normal cholesterol but a high calcium score?
Let me help Howard out with the GI map. The GI map actually has a section where it's listed potential autoimmune triggers. So if you have higher levels of certain bacteria, they're known to be associated with particular autoimmune diseases.
There's also
So they
inflammatory
kind of
markers.
do, right.
Yeah.
They do the work for you, which is kind of, it doesn't tell you what autoimmune. One day we'll be able to say, oh, this is the pattern we see with psoriasis. This is the pattern we see in lupus. They're getting to that point. That one day we'll be able to tell. Right now, we're just able to detect markers
Right,
of
and there's
inflammation.
also a measure of gut inflammation.
Right.
Yeah.
The second question, okay, so a calcium score with normal cholesterol. Then you look at all these other risk factors. There's got to be something happening, where they just, like I said, looking back at myself, when I had a 0 calcium score 2 years before I had my events, and I had no blood pressure, you saw my cholesterol. I didn't do vitamin D, but when I did it a few years later, it was low. Who knows? Stress definitely played a big part in my life, in my situation. So what do? How do you treat? You have to look at all these risk factors, find out what's the stress going on, what is the stress of a life, how are they dealing with the stress?
Let's say it's autoimmune, and let's say that's in check.
Okay.
They're still the coronary, the high calcium score.
Right. Like, for example, rheumatoid arthritis is clearly a risk factor for coronary disease. And with lupus and scleroderma, we have other problems like pulmonary hypertension, things like that. So you're right. Then we have to look at the autoimmunity and the gut.
Chronic infections have been associated with cholesterol plaquing, heavy metals. There's a number of things that in the functional medicine world we tend to look at as underlying root causes of other problems, and may have also been associated with increased risk of coronary calcium.
Yeah. I think the heavy metals is a good thing now because I haven't read
Metals, yeah. Dr. Mark Houston talks about that. He's a prominent integrative cardiologist.
There are people who have talked about the use of apple cider vinegar for actually reversing coronary artery disease. Do you have any?
I really like apple cider vinegar. I think it's got a lot of usages. I haven't heard that one. I'm a little leery about it because I don't know what mechanism or how it would work, but hey, it probably won't hurt. That's my feeling.
It's cyclic AMP.
Yes.
It regulates that.
Okay.
Just tell everybody to eat celery juice and forget everything else you know.
Yeah.
I wanted to mention that I use a lot of keto, and I see amazing results. High cholesterol coming down, prediabetes going away, hypertension going away, labs prove it case after case after case after case after case after case. And to the woman who was speaking earlier regarding, sometimes you'll see like if they're going to do that high fat, but they're not going to bring down those carbohydrates, that's going to be a catastrophe. And that's when you're going to see those lipids go up. High fat and high carbs is going to be a problem. But if they follow the protocol and bring those carbs down, you're going to see, I see case after case after case after, with labs to prove it, they're getting labs. And bring them to before and afters.
That's great. Thanks for sharing.
And a lot of people say they're doing keto and they're not. I had a guy come in my office a couple of weeks ago. Oh yeah, I'm doing keto and I'm not losing weight. Really? What do you?
Well, yeah, and when
I just have this Chipotle bowl. And what do you put in it? Well, I just put a little bit of rice. Oh,
Right.
really? Okay. And do you have any other carbs?
Well, I had a patient that-
No, but I drink orange juice before I work out. And then I have a little bit of dark chocolate. Oh, when you have that? Well, I have it in the morning, sometimes in the afternoon, and I also have it in the evening. And he's doing keto.
Right. I had a patient, I've been on keto for 4 weeks, and I've never gotten into ketosis. Something's wrong, okay? I mean, I'm not arguing, if that shouldn't be. It can take a few days to get into ketosis if you're a newbie at it, but 4 weeks, if you're really following it, so that's why I don't recommend keto for anyone that can't follow a structured plan. You have to be regimented too, because it's even with vegan, same thing. You have to be regimented to do these diets well. Anything else? Yes.
Do you know Stephen Fry? At Stephen Fry Labs in Arizona. Do you know Stephen Fry? All right, he's got a lab in Arizona. So he has done some studies on the plaquing. And his belief is that the plaquing is a combination of inflammation, obviously, but fungus and bacteria, more likely fungus.
That's why all of it works.
Right, you're right, exactly. I haven't heard that lab. I'll have to read up on it.
He's got a paper that he put out where he did the
I don't doubt you. I mean, the thing is,
but no one's ever talking about bacteria or fungus being an origin of plaque.
oh no, they are. Oh yes, oral cavity for sure. They've actually isolated organisms in the oral cavity and what we can find in coronary plaque. It's just that it's not mainstream yet, but I think we definitely know there's a link, right, Shannon? There's no question about it.
So what he said regarding the fungus is that the Institute of Health has over 1.5 million species of fungi, but his lab could only identify 500,000. You don't know what kind of species that fungus is in that plaque.
Right, it's interesting. I'm sure there's probably a role for that,
We just don't really follow that or have heard of that.
Yeah. But do I feel there's a connection between organisms and the heart? Absolutely. Just as this in the gut, there are two main sources there. And the mouth, the oral cavity, is part of the whole gut anyway. It's where things start. Anybody else? Thank you guys, and wonderful.